Good afternoon, everyone, and welcome to the second session of the webinar series called COVID-19, Healthcare at an Inflection Point. I'm Rima Cohen. I'm the Executive Director of the Aspen Institute's Health Innovators Fellowship, a program that strengthens the leadership of innovators from across U.S. healthcare sectors and challenges them to tackle some of society's most intractable healthcare problems. Today, we're going to hear from two Aspen Health innovators on a panel called COVID-19 Testing, the Hope and the Hype. And with that, I'm going to turn it over to my colleague and the co-producer of this webinar series, Ruth Katz.
Thank you, Rima, and good afternoon, everybody. Thank you all for Zooming in today. We very much appreciate your being here. As Rima noted, I am Ruth Katz, Director of the Aspen Institute's Health, Medicine, and Society program, and we are absolutely delighted to be partnering in this series with the Aspen Health Innovators Fellowship, one of our sister programs here at the Institute. Just a brief word about the Health, Medicine, and Society program before I introduce today's moderator. Our program is the domestic health initiative of the Aspen Institute. We've been around since 2005. And what we do is bring together influential groups of thought leaders, decision makers, and the informed public to consider various health challenges facing the United States in the 21st century, one of which, of course, we're going to be discussing together shortly, and to identify practical solutions for addressing these challenges. Among our best known initiatives is the Aspen Ideas Health Program, which is the opening session of the Aspen Ideas Festival held annually on our Aspen campus in June. Unfortunately, of course, none of us is going to make it to Aspen this year, but we do expect to be back in 2021 and hope you might join us then and there. And now to today's event. Rima has already teed up our webinar perfectly. You really are in for a fascinating conversation with two of our most distinguished Health Innovator Fellows. And let me now introduce the moderator for that discussion, Margot Sanger-Katz. Margot is a domestic correspondent for the New York Times, where she writes about healthcare for the Upshot, the Times site about politics, economics, and everyday life. She is also a frequent panelist on Kaiser Health's news podcast, What's the Health? Before joining the Times, Margot was a reporter at the National Journal and the Concord Monitor, among other publications. She's also a great friend of the Health, Medicine, and Society program, so we are especially delighted to welcome Margot back to the Aspen Institute stage. Margot, thanks so much for being here. We know how busy you are. We appreciate all your time, help, and interest. And thank you to our audience for being with us. Please stay well and be safe, and we look forward to seeing you again soon. Margot?
All right, Ruthie, thank you so much for that introduction, and thanks to everyone for joining us here. We're all getting more used to these video conferencing ways of being together. I just wanted to start by a few technical updates and then introduce our panelists and then get talking. So if you go to the bottom of your screen, you'll see there are like some buttons that pop up. If you are having a technical problem at any time, you want to click on the chat option and type in there. But on the bottom right, there is another chat option that says Q&A. And I really would like to encourage all of you, as you're listening to our conversation, to please think about questions that you might like to ask our panelists. We're going to talk amongst ourselves for a little while, but I am going to reserve some time for your questions, and we really welcome them. And that is the place, that Q&A place, is where you want to enter them. So this discussion is about COVID-19 testing, the hope and the hype. I think all of us have been a little bit surprised to realize how challenging it has been to develop effective tests, how limited the tests have been, and all of the implications that have sprung from that. And we have really great panelists to help us understand what's out there and what's to come and what we can do with this information. Our two panelists are Feinglass, who's the Chief Medical Officer at Danaher, Beckman and Coulter Corporation, and we also have SreyRam Kuy, who is Assistant Professor of Surgery at the Baylor College of Medicine. You guys have longer biographies of both of them if you want to learn more about them, but let's get our conversation started. And I wanted to start with a really basic question, Shami. I thought maybe you could kick us off just about like, what are the kind of basic different kinds of tests that we have for this disease? Can you just sort of give us the background on we hear about these serology tests, about PCR tests, about all these different tests. What are these different tests?
Sure, Margot. So there's a couple. The first is the test that you're going to do if you have COVID-19. So that is generally a PCR. It's what we might call a molecular diagnostic test. That actually looks at the virus's genetic material. Those are the ones that you're seeing now more often about testing to see who has the disease. They usually take anywhere from a day or two, or we have some rapid tests that you can get an answer in under an hour. There's also a second one that can tell you if you have COVID-19 right now, which is an antigen test. That detects a specific viral protein affiliated with COVID-19. The other test is serology. Serology tells you, did I have COVID-19 in the past? Was I exposed? Was I sick and I didn't know it? And those are antibody tests. So that's the other word that you'll hear for them.
And Shamiram, can you just also give us a brief overview about why do we care about testing for this disease? Why is this an important conversation for us to be having? What are the uses of these tests?
Margot, first off, thank you so much for highlighting this topic because it's critically important. As a physician on the front lines, it's so important for me to know whether or not a patient has COVID-19 because it impacts how I take care of them, how we time their care, and how we do it in a way that prevents other patients from getting sick and helps protect my staff, whether it's the nurses, the technicians, the anesthesiologists, everyone involved. Because as you know, every time a patient enters that hospital, from the minute they enter the door and the receptionist they meet, the elevator they get onto with 10 other patients that they get onto the elevator with, to when they get to the pre-op holding area and you have a tech taking their vitals and a nurse putting in their IVs, to when they finally make it to the operating room, there's dozens and dozens of people that they encounter and that they could potentially spread COVID-19 to. So for example, as a surgeon, I do elective procedures. But elective procedures doesn't mean that they're not necessary or they're not important. It just means that it's not an emergency. So it's not something that I have to do at 3 a.m. in the middle of the night tonight. But if I wait a while and I delay their care, it could become something that's urgent or that could be life-threatening. For example, I was on call the other week and I had a patient come in. And when she came in because she was in excruciating pain, and the presentation was a perforation of her colon cancer. And this is something that if it's treated early and in elective fashion, I could do as a minimally invasive surgery in the course of a couple hours and have that patient home in 1 to 2 days back to their own home. But in a patient that has delay of care because she was, for whatever reasons, that patient ends up in the ICU for a month. The patient ends up having multiple surgeries. And instead of going home, the patient ends up going to an assisted facility or a nursing home rather than back home. So it's so important to be able to know the COVID status of the patient and so that patients can get timely, quick care.
Shami, can you talk about why we should be interested in the serology kinds of tests? Why do we want to know whether people have had COVID in the past? Why is that useful?
Sure, Margot. It's useful for a couple of reasons. First and foremost, we know if you are producing antibodies, that's how we know you're having an immune response. We know that this virus is producing immune responses in many people. You only have to look at the hardest cities hit, like New York, where they've done more studies on patients that have had the disease. So if you're mounting an immune response, then you can start thinking about when will someone have protective immunity having recovered from COVID-19. Right now, research is being done to determine what titers you need, meaning what level of antibodies you would need to be protected. For example, we know regular coronaviruses, things that give you the common cold, research done on that shows that people have immunity from reinfection, from getting coronavirus again, for 1 to 3 years. Now we're looking at COVID-19 to see what's that going to look like. So again, we don't know what immunity means yet. We don't know what level is needed. However, if you take Dr. Fauci's word for it, much like other coronaviruses, we expect that we will have immunity from this. We're just working on what those numbers look like now.
So can you guys both speak a little bit about your comfort with the quality of the tests that are out there right now? I know initially, the CDC was the only group that had an approved test, and then there was this real flourishing of private tests and public health lab tests, and now we see, quite a lot of choices for both these kinds of tests, both the tests that tell you whether you have COVID-19 right now and the tests that tell you whether you had it before. What are some of the problems with the tests? So, how reliable are they?
Sure. So I'll start with that one. When you look at what we call the molecular diagnostics or the PCR tests, you want to look for tests that are highly accurate and highly reliable. Ones that have come through the FDA now through the emergency use authorization or EUA pathway have a set of standards that stand behind them. You want something that has a high sensitivity, high specificity. What that really means when you're talking about the tests that look at, do I have COVID now? You want a low false negative rate. You don't want to have false negatives. If you have a false negative, it means you're walking around with disease and you didn't know it. So right now, the ones that have gone through EUA have a high level of confidence in, but as a consumer, you need to ask the questions about what test are you getting, and you want to ask about false negatives. When you look at serology, the FDA recently put in place a way that you have to actually have a higher level of evidence for serology than early on. There was something called Policy D, and recently the FDA scaled that back a bit. And they said, look, we need more evidence around serology. So for tests that were going through the FDA and have EUA, those are accurate and reliable. For those, you want to look at sensitivity and specificity that are high, 98, 99. Again, for that, you want to know false positive. You don't want to have a high false positive rate with an antibody test, because if you do, it means that you think you've produced antibodies, you've had an immune response, but in fact, you really haven't. So the ones that have gone through FDA that have EUA are ones that I look at as being reliable and accurate at this point.
What are your guys' levels of satisfaction with the speed with which tests have entered the market and the availability of tests right now? Like, should we be happy with how things are? Do we still have too few tests? Did it take too long? Did it take about the amount of time you would expect it to? Like, what are some reasonable expectations, and where are we right now?
So SreyRam, you want to start as the clinician on the front?
Sure. I would love to actually go back to the last question, if we may, Margot, about the importance of confidence in the test. And that is so important for me, because if I test my patient in pre-op on Monday, and then they have surgery on Wednesday or Friday, I gotta be confident. I've got to be able to make sure that my staff feels safe, that when they're taking care of this patient, that they have the right gear, and that that they're not going to be exposed unknowingly, because we do have to take extra measures when we have a known COVID positive patient, and if we have false negatives for the PCR-based testing, that would undermine the whole system. For instance, when we do a surgery for a COVID-19 patient, we have to terminally clean that room in a specific way. We have to do those surgeries only in rooms that are reserved and isolated just for COVID-19. And because we are not yet at that point where we have 100% confidence, we do universal measures, such as when we intubate a patient, when we put a patient to sleep and we put a breathing tube in their throat to allow us to do surgery. We do it in such a way that regardless of the patient's COVID-19 status, we don't have anyone that's not an essential part of the intubation process in the room, and we wait 20 minutes before we allow people to come back into the room. And that's because, one, if someone gets tested on Monday, it's not necessarily true that they didn't become exposed between then and Thursday or Friday, and two, we're not yet at the stage of 100% confidence. But I'll go back to Shami.
Well, just to follow up on what you've just said, it sounds like you don't have total satisfaction in the kind of quality, speed, and reliability of the tests right now, or your institution doesn't because they still feel like they have to undertake these universal measures. What would it take for you to feel more confident? What is the kind of testing regime that would make it easier to know what are the right procedures for each patient?
That is really important. And the problem is, like, at this point, we're I think all of us across the globe are building the plane as we're learning to fly the plane. And so I don't fault anyone for the point where we're at. But I think that a lot of us feel that once we actually get to a vaccine and we can have a sense about whether or not there's some immunity, that's where we have a great deal more confidence, and perhaps these universal precautions may not be as critically necessary.
And I think the other thing to look at is, especially when we look at serology, right? Is someone mounting an immune response? But the other benefit of serology is looking at population surveillance. So many of us believe, because we've looked at historically at other pandemics, that there will be some sort of second peak or second wave of pandemic. And you want to be able to predict that. So using serology early enough before you have that second peak, but late enough so people have mounted their immune response is really important, because it's going to allow you the ability to predict who in your population is at risk, right? So with all of the social distancing, all of the hand washing we're doing, all of the mask wearing, it's really important. These are what we call the non-pharmaceutical interventions that we have. Testing is helpful for that because it can tell us in conjunction who has the infection right now. So when you're doing molecular testing or antigen testing, and then we can do contact tracing and we can look to isolate the groups of people, like the ring of isolation around the person that's infected. With serology, you also can look across all of our communities to see what's the burden of disease there. And frankly, how many more people do we have that have never had disease and therefore have no immune response that they've mounted to COVID-19? And how do we prepare for the next wave of infection that might come? Because as we know, at least in the Northern Hemisphere, we expect to start seeing that potentially, if you believe the models, in the early fall.
I'm curious, and I know, Shami, you sort of started to touch on this, but I think a lot of individual people are trying to decide whether they should get a test, one or both of these kinds of tests, and also to know like which test to take, because there are so many different vendors and they have different status in terms of their approval and their reliability. What kind of advice would you guys give to just, ordinary people? Maybe they're not coming in for surgery, but they feel a little under the weather. They're wondering if they should get a test, or maybe they lived in New York City or some area where the disease was really prevalent and they're wondering whether they might already have immunity. Is it a good idea for people like that to get tests? And how can they make sure that the tests they're getting are giving them information that's useful and it doesn't give them some kind of false sense of security due to either false negative result on the PCR type test or a false positive result on the serology type test?
So I think first and foremost, you want to make sure you understand, or that your physician understands, if they're prescribing the test, what the test statistics are, understanding what the sensitivity, specificity, what I was saying, false negative or false positive are. In addition, you want to use the right test for the right person at the right time, right? So for me, I want to know if I have antibodies to it, right? I travel the world globally, right? So I spend a fair amount of time in China. So I've been fine, but I have wondered, hey, was I someone who was asymptomatic but had COVID, and do I now have any level of immune response to it? I mean, full disclosure, I work for a company that manufactures tests, so it's maybe more in the forefront of my mind. But when I talk to any of my other physician colleagues, all of us are wondering, have we had it? Do we have an antibody response to it? And that helps us kind of think about what we might do next. But when you look at, am I sick now? If I'm answering the question, am I sick now? Then I'm having either a PCR test, or there's a couple antigen tests that have come onto the market. Both of those will give you that answer. But you need to work with your clinician, because Some of those have a higher false negative rate than others, and you need to know what test you have to know whether you need to do what we call a reflex test or a repeat, something that will ensure that if you're positive, you're really positive, or if you're negative, you're really negative.
And
Sorry, go ahead.
if I could add, Margot, what Shami said about the individual level is absolutely spot on. And if I could add on the population level, there are certain specific populations that are higher risk for COVID-19 and that should be a higher consideration for testing. And as a group here at the Aspen Institute, a group of us collaborators have been working on developing a strategy that would help either state policymakers or national policymakers. And I think the highest priority are those who are high risk for exposure, such as frontline healthcare workers and first responders. There's 9 million frontline healthcare workers and nearly 1 million first responders in the United States. And as they go into homes responding to a 911 call, or they're entering homes where they don't know what COVID status of the folks there are, or they may be bringing that exposure to there. Other groups that are high risk that should absolutely be considered for testing are essential workers whose functions are essential for our community. And this is a group that oftentimes historically has been under-recognized, such as those who are working in the food and beverage processing industry. We have about 1.5 million of those. Those who are working in the waste management, just examples, they're absolutely critical. If we don't have the janitor cleaning the hospital cannot keep running. If we don't have the people bagging the groceries at our stores, we're not able to function. And then other groups are those who are undergoing procedures and chemotherapy. In the US alone, we have 177 million patients who are undergoing elective procedures. And as we mentioned, elective doesn't necessarily mean that it's not needed, it's just that it's not yet urgent. And in some cases, if you delay those, they can become urgent and emergent. And with chemotherapy, knowing the COVID-19 status is absolutely critical because you're impacting the immune system.
I'm curious, for all of these different types of uses that you guys are talking about for workers who are encountering a lot of people in their daily jobs, for healthcare workers who may be dealing with at-risk people, for patients who want to know their status before they have a treatment that affects their immune system, for the kind of surveillance to see how broadly this disease is penetrated, for all of these reasons that these tests are useful. Like, what volume of testing do we really need in order to achieve those goals? How many tests will it take before we really can test all of the people that you guys think we need to test in order to protect the vulnerable people from infection and also to really understand where we are in this pandemic?
So, Margot, it's interesting because that question has many answers. It kind of depends on what's the goal with testing. So far in the US, according to some statistics The Atlantic put out, there's been 11 million tests done. We're doing around 300,000 to 400,000 tests a day. The majority at this point are probably more of the PCR tests. But I've seen ranges from 1 million to 5 million tests per day to open up our economies. These numbers are coming from a variety of different sources. Both Hopkins, Duke, and Harvard have been working together on modeling that looks at this. You have Paul Romer talking about testing everybody every 14 days to reopen safely. So there's a variety of numbers, but it really comes down to what are you trying to do? So if one is you want to identify and isolate anybody who is currently ill, those are the Am I Sick Now tests. Mm-hmm. Those are the numbers where they're looking at around 1 million a day to maybe 5 million. But then you have this whole other set of what am I going to do in order to anticipate and plan for this second wave of pandemic, hoping that it's smaller than the first one. And that's where you look at serology and you say, okay, how much of my community is impacted? And those are more tests because you want to test the entire community if you're going to make those predictions. So again, it depends on what question. What's interesting to me, though, is I was just on another webcast listening to actually the governor of Rhode Island, who's also a member of the Aspen Global Leaders Network. And she talks about getting a workforce out when there's an outbreak within 4 hours to do identification and contact tracing and moving tests out to the field immediately and serving the neighborhoods that have higher density in her state in Rhode Island and moving those forward. And testing is a big part of it. But even she said, we have a certain number of tests that we've done. We're going to ramp up doing more tests until we can reopen fully our state. But as she said, we need the number of tests we need in order to test every individual that has come in contact with someone to make sure they don't have it. And then we need tests to look for what the burden of disease is in the population so we can fully understand that.
One question that I feel like is raised by having all of this testing and the fact that this is a disease, obviously, that's easily spread from one person to another is what should we do with the results, and what are some concerns about privacy or civil liberties that may be associated with having these results? I know there's been some conversation in other countries of having these sort of immunity passports where if someone gets a test that says that they've had COVID-19 in the past, that might give them more rights to, go out into the world and work and things like that. With the kind of contact tracing that you're talking about, where you're trying to figure out who may have been exposed, that is related to a lot of people's personal information. How do you guys think about those issues? Do you think there are particular issues of privacy or civil rights that are attached to testing for a disease like this?
So I can start with that then, and Shami, if you want to add on afterwards. With contact tracing and with COVID-19, this is uncharted territory that we're in, and I think that with contact tracing, if we're going to do it correctly, it is an invasion of privacy, but this is what we're doing in order to save lives and to flatten the curve. There's no question that it is an invasion of privacy, but so critically needed as a public health measure. In terms of the implications of having a positive test, I think there's a lot of areas of inequity, because if you're COVID positive but you're asymptomatic, you need to physically isolate. But for many who don't have the economic luxury or the ability to physically isolate, that is extremely difficult and economically disastrous.
Shami, do you have any thoughts about what we should be doing with the results of this test, or what are the questions that we need to be thinking about and answering about that?
Yeah. For me, it's looking at how do we inform future treatments and vaccine, right? So again, both testing modalities are necessary in order to produce treatments and vaccine in the way those pathways develop. So for me, from a public health doctor standpoint, which is what I am by background, I'm looking at how do I get enough surveillance in my community to know how to protect that community, but while maintaining people's individual freedom and privacy, right? So first and foremost is as a patient, I want to know, I'm thinking about how do I assess my health risk about COVID? And testing is part of how I assess my risk. There's a few apps that are out there now where you can input the data of the disease burden in your community, meaning what's your case number. Johns Hopkins is providing a ton of data on what are the numbers in the US and globally. You put that in, you put in what your testing status is, you put in who you've been exposed to, what your travel is, and you can kind of get your sense individually of what's informing your health status. But from a community standpoint, much like other infectious diseases that we report to public health authorities, I think COVID is one that we need to consider reporting because we want to control it. Look, everybody wants to tamp down this pandemic. It is a pandemic. We haven't seen one in our lifetimes, and we want it away. In order to do that, testing's part of it, but we also need the individual information. So for me, honestly, on this one, I'm happy to say, take all my testing data. I will give you all my other vital statistics you need to be able to pool it and share that data. And sharing those data are important. And there's a lot of people that will have open data innovation for this and will gleefully give their data. And there are others that say, no way, that's a complete invasion of my privacy. You're going to misuse it. There's going to be discrimination. You are going to say, oh, you were COVID positive. It's because of where you come from. We can run down an entire racist track there. That's not what we want to do. So there's going to have to be some balance around data. But again, from my standpoint, take all my data because I want this gone.
So I want to have some time for audience questions, and we have a couple of good ones already. If you have a question that I haven't asked yet and that you want our panelists to answer, click on Q&A, type it in now. It's getting down to the wire here. We have a question from Whitney Zatkin, who asks, what level of testing is appropriate for school and other gathering spaces in order for them to safely open?
That's a really good question. Whitney, the experts are a bit split on this right now. We think that the level of testing that has to happen is a combination of PCR or antigen testing, meaning who actually has COVID-19, but maybe asymptomatic, so they're spreading for a period of time and they don't know they're sick. And you also want serology because you want to know what's the burden of disease in the community and what's the level of immunity. So as we look to go back to school, there's testing and then there's non-pharmacological interventions, meaning the hand washing, the physical distancing, the masks, the making sure if you're outside. I know in some cities, outside dining is open, but everybody is slowly moving through the phases to open, and physical distancing is a big part of that. I would imagine testing is going to ramp up. I've seen, I think it was the University of California system, one of their institutions was talking about doing serology for all of their students, as well as some level of PCR or antigen testing to know who's asymptomatic but positive and who had it in the past, so that they can figure out how they're going to open those dorms, who's going to be in the dorm, whether they're going to have people go to school in shifts or not. So we're going to see phases of this, but what I can tell you is it's not going to be a light switch, meaning it's not a quick on off. We are in this for the duration, and we want to move at a pace that is appropriate to keep the disease under control.
We have a question from Lynette Eich, I hope I pronounced your name right, who asked a good question. She said she's a little bit confused about immunity. If you have immunity, why is it that you don't have immunity from flu forever? Like, we get a flu shot every year, even though like many of us either get the flu or had the flu shot. How is this the same or different than that? And you know, how are we going to be able to predict how long immunity may last?
So there's a couple questions in there. I'll start with the first one, which is about immunity. So right now, we know that someone's having an immune response. The reason we can't say how long that immunity lasts yet is because, frankly, we haven't had the disease in the population long enough. So what we can say is we know with what I call garden variety coronavirus, the one that causes a common cold, we've seen that it confers protective immunity for about a year, in some cases 3. When you look at the flu and you talk to flu researchers, they say, well, usually when you get the flu in 1 year, you have immunity from the same flu for about 9 to 12 months. But the reason you get a flu shot every year is because the flu virus mutates a heck of a lot. Coronavirus does have areas that you can see genetic mutations, meaning changes or variation in the actual virus. But according to researchers and what they know now, there are fewer. So for physicians, what we say is, well, flu is a type of virus that mutates a ton, and that's why every year you're getting your flu shot, and that's why you're not immune year over year, though frankly, there may be a little bit of immunity conferred year to year. Whereas coronavirus doesn't mutate as much. And so they expect COVID-19 to behave like the other coronaviruses do and have fewer mutations. There may be some, but not as much as the flu.
A question from Bob Handler. Many of us have put off medical and dental visits for some time. What should we be asking offices about staff testing before feeling safe about going in?
That's a really good question. I was actually doing telehealth yesterday, and one of my patients on the video conference said, you know, Dr. Kuy, I was supposed to do a hip replacement, and I canceled it because I was afraid to come into the hospital because I was afraid that I would catch COVID-19. And as I'm talking with my colleagues across the country, this is a fear that's seen over and over again, and we're seeing less people show up in the normal numbers that we see for stroke symptoms or heart attack symptoms. So I would say, do not put off the care that you need. There are different modalities you can do. You can do telehealth, which from the comfort of your home or your office or whatever. And you should always triage, but you should not hesitate to come in if you need to. In terms of the testing, I think that most health systems are pretty aggressive with testing their healthcare workers appropriately if they have symptoms or exposure through contact tracing. So that I don't think is as much of a concern. But my message to the lay public, to everyone out there listening, is that get the care that you need. And there are different modalities. You don't necessarily have to come in. You can call your doctor and use telemedicine. And CMS and other insurers are doing things to make sure that we remove the barriers to telemedicine.
Shamiram, is there any kind of standard for how often healthcare workers are getting tested? You know, I'm here in Washington and we see that members of the White House staff are getting a test every day. Is there something similar to that frequency that's happening in your context, or is it less often?
That's definitely not happening across the country at healthcare systems. One, there aren't enough tests yet to do that. Most health systems are doing it based on, or do they have symptoms or have they had exposure? So it's not routinely testing everyone because there are some people who are lower risk for exposure, and there isn't a standardized for what's being done, though there's certain guidelines being put out now.
An anonymous attendee asks, is it worth undergoing the serology test now, or is there still too much uncertainty in the results? You know, we've heard some messages that these tests are more useful for public health surveillance than they are for individuals. What would your advice be, and when do you, if you think that they're not good enough yet, when do you think they will be good enough?
So I actually think the tests are good enough now. The tests are better than good enough. They're good. What people saw was the FDA had a pathway that was an expedited pathway for serology. And at the beginning of May, the FDA came out and tightened the restrictions around serology, which many of us in the community applauded. So the FDA has now put in place a way that the evidence requirements are the same as emergency use authorization. So the tests we have are high quality, reliable, and accurate if you're picking a test that's gone through the EUA pathway.
What do you recommend to your patients, Sharon?
For the testing, if they have symptoms, PCR testing. I haven't had patients yet that we've used serology in any context, because a lot of times in healthcare, what we need to know is, do you have the active infection, and do we need to treat it, and do we need to isolate you? So that's what we're using most commonly in healthcare right now. I think, as Shami mentioned, serology is really great for surveillance, but we don't really use it on a practical way yet at this moment.
We have a question from someone who notes that the swab tests for the PCR right now, like many of them, are really invasive. It's kind of uncomfortable to get that swab all the way up your nose. Can we expect there to be tests that are as reliable, that are a little bit less uncomfortable for people? And is that necessary in order to do the kind of really widespread testing you guys were talking about before, you know, millions of tests every day?
So, you know, I think testing will continue to evolve, but right now that swab goes very deep into your nose, and it's important because that's where you want to sample those cells from. There are people that are working on different ways to sample, but remember, this is a respiratory virus. So you need something that's in contact with your respiratory system that gives you a high enough concentration so the test can actually work. That happens to be the deep recesses of your nose right now, but some will say coming close to higher up in your nose. But there are many people are looking at what are other options for this as we try to expand testing as well. So I would say keep watching this area. It continues to evolve. There's some great research going on in this space, and we need to get the right sample, and we'll continue to do that.
Shamiram, do you see any difficulty with compliance? Like, do people want to get the test, or are they like scared because they think the test will be too uncomfortable?
I haven't seen personally patients saying that, because most people, if they think it's going to impact their care and for them to get the right treatment, would want to. I can understand that would be a possibility, but I haven't personally seen that a lot yet.
Okay. So I think we have time for just one more question. And this question gets at some of these issues of equity, Shamiram, that you were talking about before. Are there any examples of the economic effects of the epidemic, the number of people who are out of work, affecting their access to these tests? Are these tests being disproportionately taken by people who have better economic status or more health insurance, or are they being distributed relatively equitably?
So if I can start on that, I've worked in Louisiana for a good amount of my career, and as you know, Louisiana and New Orleans has been a hot spot for COVID-19. At one point, it had one of the highest rates globally for COVID-19 new cases, and that's an area that has a great deal of economic and social disparities. And yes, getting access to the testing has been difficult, but there's been a lot of great work, like with Test New Orleans, this group through collaboration with LSU Health Science Center, where we're actually sending people out into the communities to get the people tested. And that kind of outreach, I think, is critically needed. So yes, there are social and economic and racial disparities, and there are proactive ways where we as a healthcare community can go out to address this.
And I think it's a really important point as well, Shamiram and Margot, because I am in the greater DC area, and I know that there are several programs that are working to reach everybody that needs to have a test in DC, so that access and finances aren't in the way. So there's a couple people that we've been working with who are working with the mayor's office doing contact tracing. One of our colleagues, Ted Eiton, is leading that. Another one of our colleagues, we refer to her as Dr. Lisa on the street, but Lisa Fitzpatrick is actually in the communities in Southwest DC, checking on them, making sure, do you have access to tests, or do you have a way into the system? You've got the GW hospital system also helping the mayor and reaching out to where we can get everybody that needs a test tested. And that's critically important, because pandemic and COVID-19, they don't discriminate. They hit every single one of us. For those of us that are privileged enough to be able to isolate, social distance, work from home, that's really a privilege. There are other people that can't do that. Even if their jobs allow them to work from home, their home has a lot of people in it. And so social and physical distancing is hard to do. So making sure people have access to tests equitably, making sure that people have a way to make ends meet while we're in the middle of a pandemic is essential. And all cities and counties and states, I know, have this forefront in their mind, and is really important. And it's global cooperation at this point. So we're talking a lot about the US, but many of us do a lot of global work, and we're seeing this everywhere. So the one thing is resilience.
Well, I hate to have to cut off this conversation. There are so many other things that I wanted to ask you guys, but you've been a really wonderful panel. Thank you so much for sharing your wisdom with everyone. Thanks so much to the many people who submitted really great questions. There are going to be additional events in this Healthcare at an Inflection Point series, so stay tuned. Wherever you heard about this meeting, you will hear about the next one as well. Take care.